afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. If you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the events survey will be shared at the end of the program. It is my pleasure to introduce our speaker, Dr. Mahmoud Ballout. Dr. Ballout is from Toronto, Canada, and completed his undergraduate degree in biophysics. He completed medical university at the Americas in St. Kitts and Nevis in the Caribbean. Dr. Ballout is currently a PGY-3 internal medicine resident here at Northeast Georgia Medical Center. After residency, he plans to start a hospitalist position in Rolla, Missouri. His interests are in outcomes and cardiovascular disease research. Please join me in welcoming Dr. Ballout.
Welcome, everybody. I'm excited to be here today and talk about microbial power for heart health. So disclosure, no financial interest or affiliation about materials discussed in this presentation that I do have. Objectives of today's Grand Rounds is to explore the gut microbiome's role in cardiovascular disease prevention, explore the mechanism of communication between the gut and heart, introduce metabolites that they've found in research, like the SCFAs, TMAO, bile acids, and the role in development in cardiovascular disease, discuss some potential therapeutic strategies targeting the gut microbiome for cardiovascular disease prevention and treatment. So why did I choose this research today? Because cardiovascular health remains as number one of a leading cause of morbidity and mortality in America and around the world. There's been a lot of research and treatment and dealing with cardiovascular disease. Nonetheless, we still are finding more ways and more avenues into dealing with this issue. Certainly in this regard, we find a very interesting link between the gut and the heart, and we'll hopefully explore today this research and learn some lessons from it. So the key questions: how does the gut influence heart disease? And can we target the microbiome for cardiovascular prevention? In order to answer these questions, we have to ask ourselves, what is the gut microbiome? So the gut is anatomically esophagus, stomach, small intestine, and colon, rectum, that's the GI system, and then the gut mainly is around the stomach, small intestine area. In terms of at a cellular level, it has a huge area of absorption into the body, and it's a host of many bacteria, trillions of bacteria and viruses, fungi that live in our small intestine and colon. These microorganisms have different functions, and each of them exists at different levels. So far they found that the family of Firmicutes consists about 60% of our gut microbiome. Bacteroidetes is 20%, and then Acinetobacter is 16%, and the rest are made of others. Functions, they participate in digestion, fermenting fiber, producing SCFAs and other metabolites. Immune regulation, 70% of immune cells do exist in our gut, and again, metabolite production. So how is the gut microbiome related to cardiovascular disease? Through current research, we find two ways that are also linked together. So dysbiosis, basically when you have an alteration in the consistency of the microbiome in the gut, so a disruption of the organisms in the gut or their function is what this dysbiosis means. And also metabolites that are linked to cardiovascular disease. So when you have dysbiosis, you can also disrupt the production of some metabolites. And some metabolites, for example, are linked to causing cardiovascular disease and damage, and some of them are linked to improvement of cardiovascular health. For example, here, TMAO, which is derived from dietary choline, carnitine, which usually comes from red meat, spinach, choline containing compounds, mushrooms, nuts. SCFAs, short-chain fatty acids, butyrate, acetate, propionate, produced by fermentation of indigestible dietary fibers in the colon. PAG, phenylacetylglutamine, which is made from phenylalanine by the intestinal flora. LPS, pro-inflammatory endotoxin from gram-negative bacteria, are some of the main players when it comes to the metabolites produced in the gut. So how are these metabolites linked to cardiovascular disease? So TMAO has been shown to promote foam cell formation, platelet aggregation, endothelial dysfunction, and cholesterol accumulation in cells. SCFAs in research has shown were associated with the reduced blood pressure. They are linked to vasodilation, GPR41-43 receptors. They reduce the total cholesterol, LDL-C, anti-inflammatory effects as well by inhibition of IL-12 and promotion of IL-10. They do also participate in regulation of sympathetic activity. PAG was also shown to have adrenergic receptors to activate adrenergic receptors on platelets, leading to hyperactivation of platelets and atherosclerotic events, which increases MACE in some trials. LPS, bacterial lipopolysaccharide, which is part of the wall of gram-negative bacteria, and a lot of gram-negative bacteria do exist in the gut, does trigger systemic inflammation leading to sepsis, and also endothelial dysfunction as a result. And the mechanism by which it does that through activation of the toll-like receptor, NFKB, and releasing IL-6 and TNF-alpha. Bile acids, they affect the excretion of cholesterol from the body, and they have been implicated in a decreased activity of bile acids, leading to more accumulation of cholesterol in the body, in the cells, would eventually lead to plaque formation in the vessels. So that's one way. Clinically, we've seen association with atherosclerosis, with the gut microbiome, and atherosclerosis, heart failure, hypertension, obesity, and metabolic syndrome. So when it comes to atherosclerosis, Lee et al. In 2021 and a prospective series have shown that TMAO levels correlated with higher coronary artery calcium scores and plaque vulnerability. The gut microbiome richness was also reduced in patients with CAD, meta-analysis in 2022. Increased TMAO levels was associated with high risk of MACE, regardless of conventional risk factors. And on the other hand, the PURE study did show that an improvement in the rate of mortality or CVD in patients with increased consumptions of unprocessed red meat in a diet. Other studies have shown that when accounted for the GFR, the kidney function, they did not find any significant difference between eating less red meat or TMAO levels on cardiovascular disease risk. So there has been still some discrepancy when it comes to data. And most of the data that we see here, although you have some meta-analysis, prospective series, are based on preclinical data in animal models and a lot of observational research in humans. So again, this is one way that TMAO, one of the different mechanisms that have been described, how TMAO, a metabolite of choline-rich diet from red meat, implicates atherosclerosis, increases the foam cells, making macrophages into foam cells through the scavenger receptors, decreases bile acid secretion, therefore lesser sequestration of cholesterol, increased endothelial inflammation and oxidative stress leading to dysfunction, and increased platelet aggregation. Yep. Yeah. So this is one of the systemic reviews and meta-analysis of prospective studies done in 2017 by Hyenanza et al., showing the relationship between gut microbiome and the risk of major adverse cardiovascular disease and death. What they did is they looked up 19 prospective studies from 16 publications to study the quantitative association of TMAO and development of MACE or death. And they looked at the relative risks. The results showed the increased concentrations of TMAO was associated with increased all-cause mortality, and 1.3 to 1.4 times for MACE. These were results also were adjusted for, not adjusted, but there was no difference when they accounted for other risks of cardiovascular disease like kidney dysfunction, diabetes, and body mass index. One of the studies showed heterogeneity in Black patients, so they took that one out. This is the PURE study, which was done across multiple countries, and they had a huge cohort of patients, and they looked at these two different diets. So you can see this diet is higher in fruits and veggies than the other diet. And the other diet is the Western diet, the common Western diet is what they compared it to. Higher in fruits and veggies, which consists most of the diet, nuts and legumes also rich in that, really no changes in fish, higher in dairy product, and also a lot more red meat. Unprocessed red meat is what they had used in their diet compared to the usual diet. And this showed improved outcomes in cardiovascular health and mortality in the Q5 diet than the Q1 diet. This research does show some discrepancy when it comes to red meat, because as we have learned earlier, that TMAO is a product of red meat. Nonetheless, this diet is very high in fruits and vegetables, nuts and legumes, which are where the SCFAs come from, and also a lot of the polyphenols and the compounds that neutralize TMAO and lead to the inhibition of TMAO production in the body. So that's something to consider. So heart failure is another association with the gut microbiome. One of the ways when TMAO increased levels leads to atherosclerosis, leading to MACE, and then eventually you can have heart failure from that. SCFAs, which help with hypertension and also lower inflammation in the endothelial cells, can prevent the development of heart failure. But one very important theory has been studied, shown in the retrospective studies. The gut hypoperfusion in heart failure leads to bacterial translocation, leading to systemic inflammation and worsening cardiovascular remodeling. So as you can see, as you can see here, so you have heart failure causes interstitial edema. You get edema in the gut over here, leading to dysbiosis, and you can have dysbiosis independently as well, and then intestinal damage from the bacteria and the inflammation, similar to how cellulitis manifests, for example, in the skin. You get a leaky gut, more bacterial translocation, and LPS, which causes sepsis, systemic inflammation with gram-negative bacteria. And this contributes to the inflammatory cardiomyopathies, or if you do have heart failure, you'll have from even ischemic events, you'll have a tougher time recovering, and you might have more recurrent events. Hypertension, SCFA producing bacteria were found to be depleted in hypertensive patients in a study, a cross-sectional study by Calderon in 2020. High salt diets shows reduces lactobacillus, leading to Th17 activation, leading to blood pressure elevation in animal models. Some studies did propose that the gut dysbiosis is a result of hypertension or the hypertensive phenotype rather than it being the cause of leading up to hypertension in patients. So again, that's another way of that needs to be studied further to know which is causing what. Obesity and metabolic syndrome. Dysbiosis drives insulin resistance and adiposity, which is an indirect risk for CVD that was shown in a retrospective observational preclinical studies in 2023. So how do you prevent disruption in the gut microbiome leading to cardiovascular disease. We learned through, you can have some dietary interventions. You increase your fiber intake, which increases SCFAs. They are products of undigested starch and fiber. Increase polyphenols. You can do the fermented diet, which enhances prebiotics, lowers inflammation, and reducing red meat. So if you reduce red meat, you reduce TMAO production. But as we have seen earlier, that an increased unprocessed red meat was actually helpful for cardiovascular health. So that's still an area of to look into. And all of these, we still need more clinical data to really establish results. Increasing probiotics. So these are some of the ways that probiotics lead to improvement in metabolic syndrome and cardiovascular health. Increase in SCFAs as a result of probiotics. They can modify the gut microbiome composition to increase some of the good actors that produce SCFAs and fight LPS. Some bacteria do that. And also producing other metabolites that will inhibit the formation of TMAOs, and thus leading to lowering inflammation, adiposity, obesity, blood cholesterol, all these good results. Yeah. One of the areas of research is they're looking at TMA lyase inhibitors, which blocks microbial TMA synthesis. One of the metabolites that does this is DMB, which comes from olive oil. So they're looking into developing that as a medicine. And also we've seen olive oil's implication in the Mediterranean diet, and that has been proven beneficial in cardiovascular health and clinical data. As we'll see here. So this is a nice image of the Mediterranean diet, which does correspond to the diet that is high in fruits and vegetables and olive oil and nuts and dairy in the Pure study as well, and also corresponds to our data on what they found in preclinical studies and observational studies about the metabolites of these foods and their implication on cardiovascular health. So we can see that in your diet, if you eat a lot more fruits and vegetables, olive oil, then a lot more than the rest, then you'll have a better outcome. Also, don't forget to exercise, rest, This is one of the prevention strategies. Some of the emerging therapies, the fecal microbiota. FMT has been used in research with C. difficile to treat patients with C. difficile. It has also been shown in some research here. They took FMT from lean donors and they introduced it into obese patients, and it showed to improve insulin sensitivity and lipid metabolism. This is how they do it. Keep doing that. This is how they do it in the lab. So again, TMA lyase inhibitors, DMB, fluoromethacholine, are also substances of interest that are being studied as medicine. Also bile acid modulators, FXR agonists, and personalized nutrition, tailored diets based on microbiome profiling. So they will profile individual microbiomes and they will design nutrition for personalized every individual. And biomarkers. Cleveland Clinic is looking at using TMAO levels in assessing for risk of developing atherosclerotic disease. We currently use ASCVD, so they're trying to use that as well as a marker to check. Yeah. So this is an overview of the PREDICT studies. The ZOE PREDICT studies, the tailored personalized nutritional diets. So what they did is PREDICT 1, PREDICT 2, and PREDICT 3. This is a series of studies across multiple health organizations and universities across America and the UK and other countries. And what they did is they looked at two separate diets, and then they assessed the response after you eat and how it compares, the postprandial responses after they had did a profiling of the microbiome of the individuals in the research. So the different studies that they have done is really capitalization on each. So the first study used healthy subjects, and they used twins as part of these subjects. And the second study, I used very compliant individuals from the first study, a subset of individuals that were very compliant with the first study. They took them, they did another study on them in the UK. The third study in PREDICT 1 Plus, they did on the twins, and they used it in the clinic and at home. And the third study as well is they compared people with high and low CVD risks and added cardiometabolic endpoints, liver fat and vascular function. PREDICT 2, they used subjects in the US, and the PREDICT 3 as well, they did subjects in the US, and they increased their data, their subject numbers. PREDICT 3 study is still ongoing. So this is what they wanted to achieve from these studies. They wanted to quantify and predict individual variation in postprandial responses to standardized meals in a real-world setting. So what they did on day one is participants consumed 2 carefully designed meals, which varied in macronutrients, and the scientists measured metabolic responses to these meals. Then on day 13, they consumed more of the meals that were designed for them, and they continued to monitor the blood lipids and glucose responses with the CGMs. And they also monitored their sleep and physical activity and stool samples for gut microbiome profiling. So the results that they got out of the first study was The genes accounted only to 30% of the variation in glucose response and 4% variance in triglycerides. So even twins had significantly varied results. That's how they were able to study how genes affected the postprandial response in subjects. The time at which patients had the same meal did not really affect the response to the same meal. So having the meal itself was more effective on when you had the meal, right? Gut microbiome accounted for more lipemia response variation and less glucose response variation than meal macronutrient composition. So compared to like if you had a meal that's made of this much fruits, this much red meat, this much dairy, and they compared that to the gut microbiome composition and how it affected the lipemia response and how much lipids you have after the meal and glucose in your blood, they found that the gut microbiome composition had more effect on how your body absorbs glucose and lipids into your blood. Meal composition did have a significant impact on the responses as well. So having said that, it doesn't take away from how the composition of the meals impacted our absorption of glucose and fats. And meal timing, exercise, and sleep had just as great impact on postprandial responses as macronutrient composition. So basically, if you have your meals, the same meal for breakfast, you will have a lesser amount of glucose in your blood than having the same meal for lunch. So when you have it throughout the day, did affect how much you're going to absorb into your body. And they had higher glycemic response to lunch than breakfast, basically. So they went ahead and fed these data into a machine learning model to predict postprandial glucose and lipid response to meals for individual people by taking into account the above variables, which would help provide personalized food recommendations. So now you can actually log into the Zoe website, and they will try to work with you into providing a personalized diet, taking into account all these factors. So research gaps, having spoken about all these topics, we find that still in research studies, we haven't been able to establish causality versus association, as we have learned that in people that were hypertensive, some studies have shown that the hypertensive phenotype affected the microbiome changes rather than the other way around. And some studies have shown that SCFAs were implicated in lower blood pressure and improved endothelial inflammation. So what is causing what is still an area of research that clinical studies are important to determine causality versus association. Long-term effects of microbiome modulation. Again, we need more studies and we need longer studies to really follow if we change the microbiome or if we go in a probiotic diet or a diet high in fiber and probiotic on a long term. How is that going to work? A lot of the research that we have is more of a short-term research. Inter-individual variability. They're trying to account for that with the Zoe predict models. And I think now with technology that we have, more people will work on these things. But, when you're doing clinical studies, knowing that you have inter-individual variability, that will make it very hard to come up with a conclusion on causality, association, and things like that. And also, throughout medical research, lifestyle modifications, especially in cardiovascular disease, hasn't been studied well because lack of incentive for it. You're not developing a drug, so people, will not benefit from that, so they will not study it, usually. So hopefully these gaps get crossed and we can have better results. Conclusion, gut microbiome has been shown to be a key player in cardiovascular disease pathogenesis. Solutions, you can add more olive oil, properly sourced, however, and increase fiber, diversify plants and meats in your diet, a lot of fruits and vegetables, and pre and probiotic agents. More clinical research need to be done to better define nature of the relationship, and personalized interventions and novel therapies are being worked on. Okay. So some of the questions. Case 1, patient, 55-year-old male with recurrent MI, LDL controlled on statins. They checked the serum TMAO, which was 15 micromoles. Normal is less than 5. What is the most suitable intervention? A, restricted diet plus probiotics. B, personalized nutrition. C, continue current management. A plus B, or all of the above.
Would you like us to answer?
Yeah.
Okay, great. What do we think? All of the above. We're going to go E, all of the above.
It's D.
D.
Yeah.
A and B.
Yes, it's D. So, choline restricted diet plus probiotics and personalized nutrition. If you can continue current management, you're not really you're not accounting for the increased TMAO, which is associated with high risks of MACE. So. And case 2, 68-year-old female with fatigue, edema, and increased CRP. Stool analysis showed decreased bifidobacterium. Would you recommend a higher fiber diet plus omega-3 supplementation and effort to lower inflammatory state as part of best intervention strategy? A, true and recheck CRP in a couple of months. B, false, more research needs to be done.
A.
I mean, I think it's B. We still need more research to know if we should be trending CRP and yeah, but definitely high fiber diet, omega-3 supplementation is always a good recommendation. All right, thank you, Dr. Gross and Dr. Raje, for your mentorship and guidance. And thank you, everybody. We can take some questions.
Thank you, Dr. Ballout. Any questions or comments in the room? And if you're viewing online, please enter it into the Q&A section.
I'll give my 2 cents opinion. One of the things that help you fantastically, the study is a little bit skewed. I've been following it pretty much. It leaves a lot of gaps. First of all, that these people have to the degree of cardiovascular, involvement. You know what I mean? And the other one that's going to be real quick, kimchi helps you increase your flora like you wouldn't believe. And the other one is going to be sauerkraut. Those are the 2 very high potentials that will do it. Get rid of your seed oils. Do not cook with any seed oils. That will destroy your cardiovascular system so fast it's not even funny. And the best 3 things to cook with is going to be extra virgin coconut oil, tallow, and lard, believe it or not. but they won't tell you. And the best statin drugs there is out there is, guess what? Niacin. Not isoniacin, niacin. The real one that gives you the flush. That will lower you, fantastically, So those are the main things, kind of, and then you got to go on other things. Yeah, lower your salt and the whole thing. And what type of salt do you take? Because I take red salt, okay, which is the best salt there is in the world. I just call it red salt. Because the other ones have microparticles of plastic in them, believe it or not.
Thank you very much.
Okay. Okay, we have a comment here.
Hey, Dr. Ballout, very nice presentation. I was wondering, this pure diet, it seems like it has a lot of overlap, especially with DASH diet, and then maybe some components of Mediterranean diet. Did the authors address that, and did they, look at improvement in blood pressure and hypertension as benefits, that they saw, or just did they look straight at MACE events and cardiovascular events?
I'm not really sure about the hypertension. I can look it up and get back to you on that.
Oh, by the way, and another little thing, you got the one of the best diets there is ketogenic diet, keto carnivore. But guess what? Carnivore diet increases faster and better your microbiome in your gastrointestinal tract, and the chances of you getting cancer are even less than with the keto diet. So it's incredible how the gut responds. But then tumors do fermentation, and what do tumors need? Sugar and carbohydrates.
Great presentation. I was just wondering, in one of the diet you showed, you mentioned there's a lipemia seen with the certain microbiome profiling. Like if somebody eat the food post-prudential, there has increase in lipemians with certain microbiome. I wonder, what is those strain or profile, if you happen to see that?
Yeah, in the Zoe Predict studies, so basically what they did is they did dried blood spot assays to measure for the lipid profile after the meals. And that's how they were seeing the lipemia in the postprandial time after people ate.
Okay. Gotcha. No, I was referring more to you showed initially the diagram with the firmicutes, bacteroids. There's different microbiome breakdown. And out of them, I wonder if there is certain combination which is seen with the certain people where they have more lipemia response, like they have more ratio of firmicutes compared to bacteroids. I wonder if there's something like that, if that mentioned in this paper or not.
I'm not sure.
Okay, no worries.
That's what I thought.
Thank you.
Thank you, Dr. Ballout. Appreciate you tackling this complex emerging area of the scientific literature. It's very fascinating, and I like the emphasis kind of you placed on lifestyle and diet, nutrition, and which lends itself to the microbiome. So what I presented on for my grand rounds in residency, and it was cool to see all the studies that have been published in the interim. And I think just given how new this field is, it makes sense that it's kind of just like a smattering of what's been published. And I think it's yet to really be organized and made systematic. And so we're still at a very young area in the field. But yeah, I just appreciate your topic and all the new research you shared with us.
Thank you, Dr. Gross, and thank you for your cooperation on the
Thank you, Dr. Ballout.